So welcome friends, we would study now regarding community ophthalmology, and then we would study regarding few important investigations in ophthalmology which can be asked in the exam. So after that we would basically take a lunch break of 30 minutes around 1:45 to 2 o'clock. I would try to finish, and then we would take the lunch break. Okay. So first of all, community ophthalmology, what would you basically need to remember regarding the community ophthalmology? So remember last year there was a question regarding the what is the criteria for blindness. So they would be definitely asking regarding the NPCB. So first of all, there is a name change earlier. इसमें आ रहा है सर नो ऑडियो. इसमें लिखा हुआ है सर नो ऑडियो. क्या चक्कर है? ऑडिबल है नॉन ऑडिबल है? ऑडिबल है. एक बार चेक कर लेना. ऑल ओके. ठीक है ठीक है. हाँ चलो लेट्स फाइन. सो first of all, there is a NPCB, that is the National Program for Control of Blindness. Now the word has changed because we have achieved our target. So anything which is before the 2020, now you do not need to study that, but now what you need to study is the NPCB VI. So the full form is National Program for Control of Blindness and Visual Impairment. Okay, so this is a 100% centrally funded. Okay, there is no, normally health is something which is a prerogative of the state control. So this is a 100% centrally funded program. So all the program or the directories, everything is basically on the center that has to be given. It's not state policies. Now what are the important things that have now changed? So first of all, the NPCB now says that earlier, have you ever heard about there are camps going on, surgical camps going on? So now we have lot of doctors, we have lot of ophthalmologists, lot of hospitals. So now it is not the activity, the camp is not, the surgical part is not done in the camp. This is a new approach which is called a reach in approach. So if we conduct a camp outside, so there we collect the surgical patients and we basically tell them to go to the fixed facility of the hospital for surgery. There is no camps that are being now promoted in the National Program for Control of Blindness. Second thing is, they are basically getting more public-private partnership. So not only the public infrastructure, the private infrastructure should also come, and whatever the surgical intervention is done, so they can, the private institutions can basically get reimbursement. Okay, so public-private partnership, interrelationship is now promoted. Last but not the least, the new hospitals, the new programs are now basically done in those places where there is a paucity of services. Okay, so we basically go for villages as well as tribal areas for new institutions. So this is a change in the policy which has come after the NPCB VI, that is the National Program for Control of Blindness and the Visual Impairment. Now I come to the questions which are asked. So the first question they ask is, what is the most common cause of blindness in India? Can anyone answer? So the most common cause of blindness in India is cataract. Okay. The second cause is glaucoma, and the third one is refractive error, followed by any surgical complications, and then comes the others. So this basically constitute 95% of all the causes of the blindness. The first cause is, most important cause is cataract. Remember, whenever we talk about cataract, cataract is something which slowly and slowly decreases the vision. Okay, but the best thing about the cataract is that the cataract can basically, any blindness because of cataract can be treated. So this is the cause of treatable blindness. Do you get my point? Give me a thumbs up. But when we talk about glaucoma, if there is a blindness because of glaucoma, then this cannot be treated. Okay, so it is non-treatable. But basically what we can do is we can prevent blindness by glaucoma. Are you getting my point? So let's say if I have a high intraocular pressure, this high intraocular pressure can slowly and slowly damage my retinal nerve fiber layer. So before the damage is being done, before I become blind, I can basically use eye drops, I can get my laser done, I can basically get my surgery done to avoid the blindness. So glaucoma is a cause of preventable blindness. Do you all agree? Okay. Now you say, sir, what is the definition of blindness? So earlier there was a lot of confusion regarding the Indian criteria and the world criteria. Now the Indian and the world criteria, they are the same. So what is the criteria of blindness? This was last year question. So the criteria of blindness is less than 360 vision with the available correction in my better eye. Okay, this is criteria 1. Criteria 2 is less than 10 degree of vision in the fixation point. Now what this actually means, you have to just understand. Now let's say there is a patient A, Ramesh. Ramesh comes with vision of 6/16 right eye and 1/16 left eye. My question is, can he be told as a blind? Yes or no? So my question is 6/16 right eye, 1/16 left eye. So one eye, right eye, it does not come under the criteria, but left eye comes under the criteria. Remember, we always have to see the better eye. So this patient is not blind. Okay. Now second example is, let's say there is a patient Puneet. He comes to the OPD with one eye as 1/60 right eye and other eye as 2/60. That is the left eye. So would it be blind? So which is the worse eye? Which is the better eye? So this is my worse eye and this is my better eye. So my better eye is 2/60. So this patient is blind because even the better eye, the patient is having a less vision. Okay, so that is how they can ask you the questions. They can ask you, they would give you vision of both the eyes and that would ask you whether the patient is blind or not. With this, we come to the few other types of blindness which is being asked. So first of all is the economic blindness. What is the meaning of economic blindness? So economic blindness is any vision which is between 6/60 to 3/60 in the better eye. Okay, so let's say if the vision of one eye is 4/60 and other eye is 1/60, this comes under the prerogative of economic blindness. Is it clear, everyone? Okay, then what is the social blindness? So social blindness is, what is the blindness criteria? So social blindness is that vision is between 3/60 to 1/60 in the better eye. Okay, this is called social blindness. What is legal blindness? Legal blindness is anything which is less than 1 by 60, that is called a legal blindness. What is total blindness? Total blindness is that when the patient is not even to able to perceive the light. Okay, patient says that, sir, I cannot even see if there is a light in the room. Okay, so this is called a total PL negative. Okay, so there is a no light in the patient. So how basically we tell that patient is a total blind or not? What we tell the patient is, we tell the patient to be, answering your question, Murlidhar. So how can basically we tell that patient is PL negative? You close the eyes. Okay, you are in a room. Okay, you switch off all the lights and take a indirect ophthalmoscope. Indirect ophthalmoscope has a very bright light, and with the very bright light, show it to the patient. Okay, I would just explain it to you. So with the bright light, you show it to the patient. Please. So what we do is close one eye, एक eye बंद करिए. So everything is now switched off. There is a dark room. We tell the patient to see on the bright light. He says, sir, I cannot appreciate this bright light. Then you show the light temporally, superiorly, inferiorly, and in the nasal. All the quadrants you show the light. If he is not able to perceive light from any quadrant, okay, remember, a very bright light, this is called a perception of light negative. Okay, thank you. So this is a PL negative patient. Okay, so this is basically called a total blindness to the patient. Okay, so that is what you have to remember, the various types of blindness. Okay, now there is one more question sometimes that is asked is, what is the most common cause of ocular morbidity? Now what this means? Ocular morbidity means that you are not coming in the criteria of blindness. Are you able to understand that, everyone? Okay, you are not coming in the criteria of the blindness, but still you have a low vision which is basically hampering your work. Okay, this is called a ocular morbidity. So any vision which is less than 6 by 18 on Snellen's chart, this is called a ocular morbidity, and the most common cause is refractive error. Okay, so most common cause of ocular morbidity, okay, or I also can call it low vision, is the refractive error. Yes, Muralidhar, this was a question, that's why I have put the economic, social, legal. They can ask like this also. Okay, so now comes the next criteria, that is which is basically next program, that is basically being run by the National Program for Control of Blindness. This is a very important program, that is called a vitamin A supplementation program. Now the patients, how to identify with values. So Muralidhar, if you have any question, you can just any specific MCQ, you can send it to me, I would answer that. Okay, chalo, let's move to the vitamin A supplementation program. So the age group that we basically use, where we have to give vitamin A supplementation, is between 6 months of age to 59 months. Okay, so up to 5 years we can basically give a vitamin A supplementation. Okay, so what we have to do, we have to give 9 doses of vitamin A to these children, and these should be given every 6 months. So let's say the child is of the 9 months, if he is less than 1 year. Okay, so if the patient is less than 1 year, you have to give 1 lakh dose, 1 lakh units. If he is more than 1 year, okay, then you have to give 2 lakh units. This you have to give every 6 monthly, and it is linked to the measles immunization program. Okay, so first dose is given with the measles. So this is the vitamin A supplementation program. Why the vitamin A supplementation program is basically run? Because if the patient has a vitamin A deficiency, there can be lot of problems that can come in the eye. Okay, so what are these problems? We call it as a xerophthalmia. So xerophthalmia is the vitamin A deficiency basically leading to the ocular issues or ocular morbidities. Okay, so what are the things that would come here? So first thing Dr. Shankar would come here is that there would be vitamin A is needed for good health of the epithelium. So there would be dryness in the patient. Okay, so the patient would have a conjunctival xerosis. First, conjunctiva would be involved, so there would be a xerosis there. Second thing is, can you see here, foamy type of aggregation over the epithelium. This foamy aggregation towards the epithelium, this is called Bitot spots. Okay, so this is called X1A and this is called X1B. So remember, X1 is basically on conjunctiva. Then comes the X2. X2 means now the dryness has come into the cornea as well. So there is a corneal xerosis. The xerosis means dryness. So after there is a dryness of the cornea, then slowly and slowly there is the ulceration of the cornea. So that is X3A. So now the xerosis has come and causes the ulceration. Last thing is the ulceration has gone to whole of the cornea and this has caused thinning of the cornea. So that is called keratomalacia. So corneal involvement starts from X2 and goes up to X3. So these are the primary signs. Now what is the meaning of primary sign? Primary sign means that the vitamin A deficiency is there. Already there is a vitamin A deficiency and now you have to treat the patient aggressively. Then comes the secondary sign. Secondary signs are XN, XF, XS. Okay. Earlier when I was in my 8th or 10th standard, so there was a video game that was coming at that point of time that is called Need for Speed. There was a game there, NFS. Okay. So similarly you can remember it with the night blindness, xerophthalmic fundus and corneal scar. Night blindness means that the patient is not able to see in the night. Xerophthalmic fundus, what this means? This means in the fundus you would get not only night blindness, you would get yellowish granular type of lesions all over. This is called a xerophthalmic fundus. And the third thing is you would get scars in the cornea. Now what is the meaning of the secondary signs? The secondary signs means that patient already have got damage due to vitamin A deficiency. Damage, irreversible damage. Irreversible damage due to vitamin A deficiency is already there. So अभी तो आती ही अभी भी आती है. अच्छा Vishwanathan, I do not know about that यार. Okay, so the secondary signs means that now the patient has already undergone damage because of vitamin A deficiency. So like a detective, you can say that this has occurred because the patient was having a vitamin A deficiency. So these are the previous signs of deficiency. These are the secondary signs. Now you would ask me, sir, what we have to do when we get these type of patients? So what is the treatment of xerophthalmia? So treatment of xerophthalmia is a bit controversial because in Khurana sir book it is written 0 day, 1 day and before 4th week, and in Parks it is written 0, 1 and 14. So I have confirmed with Vivek Jain sir, one of my senior and the the famous faculty of the community medicine, and we have come to the criteria that it is basically 0 day, 1 day and 14 day, because the Quran Sir book have written is the less than before 4 weeks. Okay, the ideal is 14 days, but it has to be before 4 weeks, that is written there, and Parks has definitely written it as a 0, 1 and 14 days. So treatment is, you have to give vitamin A supplementation at 0, 1 day, 1 day and 14 day. So you can give intramuscular or you can give oral. If you are giving intramuscular, it has to be 1 lakh units. Okay, and if you are basically giving orally, it is 2 lakh units. Okay, so 1 lakh unit here, then after 0 day, then 1 day 1 lakh, then after 14 days 1 lakh unit, and here 2 lakhs units. Okay, now this is for any child which is more than 2 years of age. If the child is less than 2 years of age, then you would half the dose. Okay, then you would give 50,000 unit of intramuscular injection or 1 lakh unit of the oral. Okay, so this is the treatment of the xerophthalmia. So remember, the treatment of xerophthalmia and the prevention of xerophthalmia, they are basically different. So supplementation is different and the treatment is different. So in treatment you have to go for more dose as compared to the one which is your supplementation. Is it clear, everyone? Okay, let's move to the next part, that is, I think school eye screening is left. Okay, so let's move to another important program, that is called school eye screening program. Now, what is school eye screening program? If you can detect there is a refractive error in a child, you can basically help the child in 2 ways. First thing is, you would basically avoid the amblyopia in that patient, that is the permanent decrease in the visual acuity. Second thing is, if you give the glasses at a right time, there would be a proper social economic development of that child. Okay, so that is the 2 reasons we want school eye screening. And I would say that being in a private eye hospital, I see that there are less patients that are coming from the government hospital as compared to the children in private hospital, because government schools, the less patients are coming from government schools as compared to private schools, because the government schools have to basically go for school eye screening program. So if there is a small child which is having a refractive error, they detect it early as compared to the private schools. Now, what is the school eye screening program? So any child which is less than 14 years of age, okay, you start with around 9 to 10 years, but any child which is less than 14 years of age in middle or secondary schools, they have to undergo eye screening. And this eye screening is basically done in the months of April to September. Now you would ask me why? Because the session starts at this point of time. So if you can basically give glasses at this point of time, this would help the patient to basically have a good academic result. Okay, and this is basically being done by the school teacher. So the question they ask is doctor required, is ophthalmologist required? No, the screening is done by school teacher. We basically put the Snellen's chart in front and we train the school teacher to basically measure the visual acuity of the child. And now what happens if a school teacher is seeing, remember, you have to cover one eye and then see the letters, then you have to cover other eye, then see the letters. So she would like it, she would have a sheet where she would write it like this: right eye vision 6/6, left eye vision 6/9. Okay, so that is how the school teacher would write. And if the vision is not 6/6, then comes the role of, she would refer this child to a optometrist. Now, who is the optometrist? Optometrist is the one who give the glasses. Okay, so optometrist give the glasses to the child, and now the vision becomes 6/6. So not every student goes. The teacher basically refers those students who are having low vision to the optometrist. Optometrist by retinoscopy and refraction gives the vision. But even if after the glasses vision is less than 6/9, let's say after glasses vision is 6/9 in one eye and 6/12 in other eye. Now this is after glasses. Do you understand? Now this has to be referred to a eye specialist. Okay, so we have a whole protocol. A teacher basically screens it, which refer it to optometrist, and optometrist, if required, shows it to the eye specialist. This is the basic concept of the school eye screening program. Is it clear, everyone? Okay, so that is how we basically do the school eye screening program. Okay, so let's move to one topic which is now too much in discussion, that is trachoma. Now you would ask me, sir, trachoma is something which you have read so many times in when you were there in conjunctiva in your second or third year. So why the trachoma is now important, and why I am teaching trachoma now in the community of ophthalmology and I am not teaching it in cornea and conjunctiva? There is a specific reason, and the reason is it is most common cause of infectious blindness in the world. That is the reason it is a very important community ophthalmology disease. But here is a good news also. The infective trachoma is the latest disease which is now eradicated from India. Okay, now this is eradicated from India. How? Because we have successfully done two programs. One is a SAFE program and other is a GET program. Have you ever heard the name? So what was GET program? GET was Global Elimination of Trachoma. Global elimination of trachoma. And how? By SAFE strategy. What is SAFE strategy? So S goes with the surgical correction, A goes with the antibiotic prophylaxis, F goes with the facial cleanliness, and E goes with the environmental changes. Okay, what they actually mean, I would just tell you one by one. So first we talk about the trachoma. Is it clear, everyone, till now? So we have basically eradicated the trachoma, infectious trachoma. Now that does not mean that we do not have patients of trachoma. We may be having patients of trachoma at 40 or 50 years, or I would say every day I see around 3 to 4 patients, but there are healed trachoma cases where you are seeing the manifestations of trachoma, not a infective trachoma. Now, in which patients you get a infective trachoma? What are the predisposing factors? Usually you get it in early age group. Okay, though males are seen more as compared to females, but females have more severe disease and they are seen more in low socioeconomic status. Okay, now there are two strains of trachoma. One is called hyperendemic trachoma and other is called inclusion trachoma. So the hyperendemic trachoma, the strains responsible, what is the bacteria that is responsible? I forgot that. Remember, Chlamydia trachomatis. So the strains, important strains are hyperendemic trachoma. You have A, B, C. So there are two strains in B, B and BA. And inclusion trachoma, you have the strains D, K. Dinesh Karthik is included in the Indians. Ankit, whatever I am basically putting here, everything is there in my notes and we have given free access to my notes in my ebook. Okay, you can see Ankit. Okay, so hyperendemic trachoma is A, B and C and inclusion trachoma is DK. You can remember Dinesh Karthik. So those who are cricket lovers is now included in the Indian cricket team. So that is how you can remember this. Okay, so now we come to the clinical features of trachoma. So first of all is the pH of the tears that we see becomes acidic. Normal pH is around 7, 7.2. Okay, here there is a acidic pH. Then the second thing is the pannus occurs in these patients. Now what is the meaning of pannus? Now pannus means that there is a vascular infiltration of the cornea. Vascular infiltration of the cornea. With the vessels, there is a opacity too. Okay, so there is a vessels plus opacity. Okay, so this is called pannus. You get pannus whenever you have trachoma. Now again, like in your conjunctivitis, your vernal conjunctivitis, allergic conjunctivitis, you get follicles on your conjunctiva. So basically follicles are the allergic reaction where in the center you can see red spots. Okay, so on the tarsal conjunctiva, I would say palpebral conjunctiva for ease, you would see red spots there. So there is a follicles that are seen. Why we should be very aware of the trachoma? How it basically causes the most of the ocular morbidity. You see the patients of trachoma, they come and they say, sir, I feel like there is something in my eyes, something is rubbing my eyes. What happens is in the palpebral conjunctiva, okay, the conjunctiva which is basically lying the eyelids, we get a scarring there. Can anyone name what is the name of that line which is due to scarring? So scarring is seen and this is basically called a Arld's line. So we get Arld's line in the trachoma. Now similar thing is, do not confuse, we get a Arld's triangle. Can anyone tell me where we see Arld's triangle? Where keratic precipitates are seen in a triangular fashion. So Arld's triangle is seen in uveitis. Arld's line is basically seen in the patients of trachoma. Okay, so next thing is slowly your eyelids, they basically have fibrotic connection, fibrosis traction band and cause adhesion between the palpebral and bulbar conjunctiva. What I mean here is, I just show you a diagram. Now this is my eyelid. This is my eyelid. Okay, so this is my conjunctiva, this is my conjunctiva. If you get addition here, okay, addition between the bulbar conjunctiva of sclera and the eyelid, what this called? This is called a symblepharon. Then slowly and slowly there is a thickening of eyelid. Because of the thickening of eyelid, we call it tylosis. There is a inward turning of eyelid. Are you getting my point? These eyelids, they turn inward. Slowly they thicken and they turn inward, and the eyelashes then touch the cornea. What is this condition called? Inward turning of the eyelid margins. This is called entropion. And then after the entropion, these eyelashes touch the cornea. We call it trichiasis. Okay, so we have tylosis, we have entropion, which causes the trichiasis. Now this trichiatic eyelashes injure the cornea, make corneal epithelial defect, and finally they cause a corneal scarring. So this corneal scarring that happens, this is the main cause of blindness. Okay, so this is the main cause of blindness in these patients. So this is the important features that you have to remember regarding the trachoma. There are few more things that are there, like the classification of trachoma, but because trachoma is not there now in India, infective trachoma is not there, so I don't think that classification would be basically asked now. But what they would ask is, how would you treat the patient? So treatment is symptomatic, because if you have got trichiatic eyelashes, you remove them. If you have got entropion, you do the surgery for the entropion. If there is a corneal scarring, you can do a corneal transplant. But the thing is, how to basically avoid these complications, that comes under the treatment. So what is the prophylaxis and what is the treatment before complications arise? This is the two things that you have to basically think about. Now the important thing is, the treatment which we can give is azithromycin. Earlier what we used to give was the tetracycline. Yes, one thing more that I left, I think one Shankar have put, the Herbert pits. So you get pits around the limbus, black pits around the limbus, which are called Herbert pits. Okay, so we come to the treatment. So treatment is, before the complication arise, we give azithromycin. You all must be taking azithromycin for a sore throat as well. Here the azithromycin that we give, that is given 1 gram, single dose. If that is not available, we give eye ointment tetracycline twice a day for 6 weeks. Okay, so the drug of choice is azithromycin. If that is not in the option, then you can basically go for the tetracycline. Now for prevention as well, for these patients to basically go for prophylaxis, if you have got a blinding trachoma in the society. What is the meaning of blinding trachoma? If the percentage of blinding trachoma is more than 5%, if the percentage of blinding trachoma is more than 5% in 1 to 9 year age group, then this can be given to whole community. Okay, so this is the prophylaxis that we also basically give to these patients. Okay, so with this we end the chapter of the community ophthalmology, and now we would basically do a bit about the various investigations in ophthalmology. Okay, Can you see this slide? Investigations in ophthalmology. Okay, so let's start with the investigations in ophthalmology. So we would talk about the most important ones, that is the electroretinogram. We would talk a bit about electrooculogram. Then we would talk about visual evoked response and the various type of ultrasound B scans and various pictures. So first of all, we start with the electroretinogram. Now, what is electroretinogram? Electroretinogram is basically the record of change in the resting potential of the eye. So whenever the light touches your retina, how this nerve impulses are formed. So these nerve impulses basically change the retinal potential of the eyeball, and this retinal potential of the eyeball, the resting potential of the eyeball, that transmits as the electrical impulses from the optic nerve to the brain, which finally makes your vision. So what it does is, the electroretinogram, I put an electrode here over my cornea and other electrode is put over my brain, and the changes that is happening between my cornea and with my brain, this is basically called a electroretinogram or ERG potential. Is it clear, everyone? Okay, so I write it here. It is record of the change in resting potential of the eye in response to the light stimulus. Now, whenever we talk about the electroretinogram, we get a figure like this. Can you see here? So it is done by the electroretinogram. We have special people who do the electrophysiological tests. So they basically are the part of ophthalmology only. Okay. So whenever we talk about the ERG, we get a wave like this. Here you can see this is 0. Okay. So this is minus and this is plus. We are talking about the amplitude. So first you are seeing a wave, this one. Okay. This is a negative wave. And then you are seeing a positive wave. Okay. Sometimes you get a small, another positive wave. Now this is called A wave. This is called B wave. And this is called C wave. So what is A wave? What is B wave? What is C wave? So first of all, the A wave is a negative wave. Okay. So you can see here the A wave is a negative wave. I call it cornea negative wave. And this A wave is because of the activity of which cells? The rods and cones. Rods and cones. So I call them the wave because of the photoreceptors. So you can see the A wave is smaller one as compared to B wave. So the amplitude of B wave is more than the A wave. B wave is bigger. So B goes with B. So B wave is because of the bipolar cells and the Muller cells. Okay. And the C wave, the small wave, it is because of the retinal pigment epithelium. So I can say that the ERG basically helpful in telling about the rods and cones features, also the inner features of bipolar and Muller cells. So a general retinal health can be basically told by this, but it is not a very sensitive criteria for a retinal pigment epithelium. Do you all get my point? Okay. So my next question to you is, can you tell me any disease where the rods and cones are basically damaged? So friends, it would be very useful in detecting that whether this decrease in vision, decrease in the quality of vision is because of the decrease in the health of rods and cones or damage to the rods and cones. Okay. So till you answer that, we basically go with the various parameters. So first parameter that we talk about is the amplitude. Now what is the meaning of amplitude? Now this is my time and this is my potential. So this is my wave, okay, A wave, and this is my B wave, okay. What is the amplitude? Now this height is my amplitude, okay. This is my height of A and this is my height of B, okay. So here you can say the amplitude of A wave is less than B wave, okay. So I write it, amplitude of B wave is more than A wave, okay. Now what is the meaning of latency? Latency means the onset of stimulus to the beginning of the A wave, okay. So this is my stimulus when I give the stimulus. This is the point, 0 point where I have given the stimulus, and here there is a starting of A wave. So this is called a latency. Are you getting my point, everyone? So giving a shock, and giving the shock basically causes the starting of the A wave. This time interval is called latency, okay. So now the third point is implicit time. What is the meaning of implicit time? Which one is the biggest wave? So B wave is the biggest wave, and this is the area of the biggest amplitude. So time interval, this time interval where I have given the stimulus and we have got the maximum response, this is called a implicit time, okay. So what is implicit time? It is time interval from onset of the stimulus to the peak of B wave. This is called a implicit time. Is it clear, everyone, till now? Okay. Now it comes, what are the cases? The question would be regarding the cells that are being assessed, and the second question would be which are the diseases where there is a decreased ERG response. So remember, any disease which basically have a effect on the rods and cones or general health of the retina, complete retina, there the ERG waveform would be decreased. Do you get me? Give me thumbs up. Okay, so what are the cases? Like retinitis pigmentosa, I told you rods are basically damaged. So what you would get is, now see, whatever the theoretical part I have given, I would tell you the practical part. So because there is a retinitis pigmentosa, so your rods are basically involved, so there would be a lot of latency. So you have basically told your friend to get up and study, but he is latent because he is weak. So he comes after 15 minutes. So there is a latency. So now the stimulus starts late. Not only it starts late, it is weaker. So even he gets up, he studies a bit, and then he goes back to sleep. So he has a latency increased, and even the amount of study that he does, that is also less. So latency is also increased and amplitude also decreased. Okay, you can say that he is studying less, also he is studying useless. Okay, so both the things are going on. So he is studying less, and also his concentration is less. So this is the worst thing that can happen. This happens in a retinitis pigmentosa. So if you are in a doubt whether the patient is having a retinitis pigmentosa or not, you do a ERG. Sorry. You do an ERG, and if the latency has increased and amplitude is decreased, this means the patient is having a retinitis pigmentosa. What are the other cases where there is a decrease in ERG response? When there is a extensive damage to the retina, like diabetic retinopathy, siderosis bulbi. So siderosis bulbi is a condition where there is a toxicity of eye due to iron. So iron deposition can basically cause the decreased response of the photoreceptors and the whole retina. And similarly, RIOFB. So this is retained intraocular foreign body. So it is also there. This would also cause problem to the patient, and the patient would have lot of issues. Okay. Now we come to the next investigation, that is multifocal ERG. The problem of the ERG here is that whenever we do ERG, it tells you about the condition of whole retina. Let's say you have taken a drug like chloroquine and it has caused damage to only your macula. The damage to the macula of chloroquine is like this. You have can anyone tell me what is this sign called? Where there is central hyperpigmentation followed by the peripheral hypopigmentation that happens in chloroquine. This is a specific type of manifestation of chloroquine. I call it bull's eye maculopathy. So there is a drug toxicity to the macula. So this is called a bull's eye maculopathy. Similar type of things can happen in other disease where macula is involved, like central serous retinopathy, cystoid macular edema, or any macular dystrophies. So how much is the damage to the retina because of these conditions? This can be basically taken care of, told by the multifocal ERG. Now see this picture. Is this hill of vision clear to all of you? Can you see this hill? Everyone give me a thumbs up. So you can see this hill here. What is happening is, whenever we talk about the macula, what is happening is the best vision is at macula. So this hill basically corresponds to the best vision in the macula, okay, or the center of the macula. If there is a damage to the macular area, this would decrease the hill of the vision. Can you see here it has decreased, okay, as compared to this one, and this is also decreased. So whenever you have macular dystrophies or whenever you have drug toxicities to the macula, this multifocal ERG, maybe total ERG may be normal, but multifocal ERG would basically show you the specific decrease at the level of macula. Is it clear, Dr. Ajit? Everyone? Okay. Then comes the next thing, which is called a electrooculogram. Now what happens sometimes is that there is a retinal problem which is called Best dystrophy. Now what happens in the Best dystrophy is there is a damage of retinal pigment epithelium. When we talked about the electroretinogram, we told that it is not a very good indicator of RPE. Remember, C wave tells us about the RPE, but it is not a very consistent wave. Do you all get my point? So we want some more investigation which basically can tell us about the RPE. So our investigation which tells us more about the RPE, that is called electrooculogram. So here what it does is we basically put the electrodes over the eyeball and over the end of the cornea. So remember, whenever we do ERG, we put an electrode over the cornea and other over the head. Okay. But when we basically do a electrooculogram, we put an electrode over the cornea and other at the angles of the cornea. Okay, angles of the eye here. And we basically see the movement of the eyeball, where the eyeball is moving, and we basically see the electrical activity there. Are you getting my point? So what we do is we put an electrode here and we put an electrode here, and we see the movement, and then we detect the electrode potential, and it tells us about the condition of retinal pigment epithelium. Now what happens in the Best dystrophy is that you see the yellow of the egg, na? There is a white of the egg and the yellow of the egg. The yellow of the egg is called yolk. So there is a disease which is called Best dystrophy, where over the macula there is a degeneration of RPE and it looks like a yolk over the macula. So when this is happening, so the ratio, a ratio which we calculate by the electrooculogram, that is called Arden's ratio, that gets decreased. Okay, so they would ask a question: a patient came to the OPD with decrease in vision and you see the Arden's ratio is less than 1.30. So what is the diagnosis in the case? Your answer would be Best dystrophy. Do you all get my point? Okay, so this is the second most important investigation which is basically being asked again and again, that is a electrooculogram. Now we come to one more investigation which is asked sometimes, that is called visual evoked response. Now what is the visual evoked response? So sometimes we get a graph like this. Okay, here we have N wave, P wave, N wave, P wave. So this N wave, P wave is basically a visual evoked response. You do not have to go into the interpretation of the wave, but what happens in the visual evoked response can be asked. So the indications of doing a visual evoked response is, it tells us about the electrical activity of your brain. Okay, so whether your eye and brain, they are coordinating or not, that is basically told. Till now we were discussing only about the eye. Okay, we were not basically focusing on the visual pathway, but if we are focusing on the visual pathway as well, then it is called a visual evoked response. Vision has evoked response in the brain. So those conditions where you cannot detect the visual acuity, you cannot see the fundus, or the fundus is absolutely normal, like in the cases where there is a brain damage, so like hypoxic ischemic encephalopathy, there is a hypoxic ischemic encephalopathy, or the patient is, let's say you have a patient from a jail and he says that suddenly I have got blind. Okay, so to basically see that whether there is a functional loss or there is a malingering, and the last but the not least is, if the patient is basically saying that I have got a brain tumor, so you suspect there is a lesion to the visual pathway. So in these cases you can go with the visual evoked response, and visual evoked response would basically tell you visual evoked response would tell you whether this patient is having actually some problem in the visual pathway, or he is just feigning or basically lying to the doctor that he is having some issues in the eye. So this is called a visual evoked response. Okay, so with this I come to the last topic of the day, before which we take lunch. We would be talking about a ultrasound B scan. Now when we do a ultrasound is done to see hidden things. Let's say we do a ultrasound of the abdomen. If we do the ultrasound of the abdomen, what we are basically trying is, we want to see which we cannot basically see from our eyes. So let's say there is a mature cataract, there is a corneal opacity, there is a small child who is not basically uh, is, uh, so lunch break is after this year, okay, just after ultrasound. So if the patient is basically doing this, if the patient is having issues with the not opening the eye, or there is a mature cataract, corneal opacity, some hyphema, uveitis, you cannot see the posterior part, you do not see the optic nerve, you are not able to see the retina, the vitreous cavity. So in that means where we can basically do a ultrasound B scan. If you can see here, this is a picture of ultrasound B scan. This is the lens shadow which you are seeing. This black area is vitreous. This is whole retina, and behind retina we have the sclera. This shadow you are seeing, this is the optic nerve. Okay, so this is what is the ultrasound B scan usually have in a normal person. Okay, so now whenever we have B scan, B means brightness, you see the various brightness spots. Then we have a scan also in the ultrasound. A scan, A means amplitude. Can you see the various lines here? Okay, so whenever there is a opacity, give me a thumbs up if you understand this. Whenever there is a opacity, or there is a blockage, or there is a hindrance to the movement of the sound rays, you see some spikes. Okay, if you are having a very light opacity, you would see medium spikes. If you have, like in a blood, or let's say you are having some infection in the vitreous cavity, okay, so there you would see mild spikes. Okay, if you have is this done by ophthalmologist? So ultrasound, A scan, B scan are done by the ophthalmologist. Okay, so the second is, if you have large spikes means there is a more consistent, more viscous thing that is coming in front of your sound rays, like calcium. Or if there is a sclera, so if there is a mass there, let's say melanoma, okay, then you would see large spikes. Okay, so this is, we have USG A scan as well as B scan whenever we do it. Okay, so what are the various diseases where we can do the ultrasound? We can do it in lot of diseases like retinal detachment, PHPV, that is the persistent hyperplastic primary vitreous, choroidal detachment, retinoblastoma, to detect any foreign body in the eye, drusen's in the eye, if we have any intraocular tumors, endophthalmitis, and lot of conditions. Okay, so we would basically show you few of the questions, and that's how we would understand it. So next 5 minutes, please give your full attention before the break. So first question is, a patient presented with the loss of vision and USG B scan reveals a picture like this. This patient may be suffering from, your options are choroidal detachment, posterior vitreous detachment, endophthalmitis, or retinal detachment. Try to answer. So if you can see here, there is a membrane. This is a membrane, and this membrane is attached here. This area is called optic nerve head. So these are the neurosensory retina which has detached from its bed. So there is a fluid here, and the retina has detached from its bed. So this is a patient who is having a retinal detachment. Okay, so how the other things basically are seen? So let's say if we have a choroidal detachment. So choroidal detachment can also look like same membranes, but because choroid is a something which is a more thicker one and more vascular ones, usually you get a picture like this. You get a picture like this, whenever mounts are there. Now this is happening in a choroidal detachment. Is it clear, everyone? Okay. Now comes the posterior vitreous detachment. What is the meaning of posterior vitreous detachment? This means that whole vitreous, normally I told you the vitreous is attached to the internal limiting membrane of the retina. Now what is happening is that whole vitreous get detached from the retina. Now this is my vitreous. Vitreous is a jelly type fluid. Whole vitreous is detached from the retina. Okay, this is my retina. This is basically called a posterior vitreous detachment. Remember, whenever there is a retinal detachment, in retinal detachment, the neurosensory retina is detached from the retinal pigment epithelium. Is it clear, everyone? Okay, chalo, let's move to the next question. Okay, so next question is, a 26-year-old male came to the OPD with sudden onset of floaters and loss of vision. On ultrasound B scan, you get a picture like this. What is the differential diagnosis? So in the picture you see here. Now what is the hint that is given? The hint given is 26-year-old male, sudden onset. There is no history of any surgery that is being done. And here you can see there is a dust-like particle in the vitreous cavity. Are you able to see that? There is a dust-like particles in the vitreous cavity. So what is the diagnosis here? Your options are endophthalmitis. So definitely it is not a retinal detachment. Definitely it is not a posterior staphyloma. Now your options are gone with the vitreous hemorrhage and endophthalmitis. Okay, now let's say you do not know about endophthalmitis, you do not know about vitreous hemorrhage. Still you can answer the question. A 26-year-old male, he would not have a endophthalmitis. For endophthalmitis, you must be having some pre-existing strong history, maybe like a history of cataract surgery, maybe a history of trauma, perforating trauma, immunocompromised situation. So you are not having a history of that type of thing. So this patient is having a sudden onset floaters. A young child or a young adult who get sudden floaters. Now this may be because of the sudden vitreous hemorrhage, and this disease which the patient has is called Eales disease. Have you ever heard the name? Anyone? Give me a thumbs up. So in Eales disease, you can have picture like this where you are seeing dot 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 all over the vitreous cavity. So this is blood which is accumulated in the vitreous cavity. Now same thing can be an endophthalmitis if the question would have been a 65-year-old male came to the OPD after the cataract surgery and he says that, sir, I have lost the vision and I have a lot of pain. So similar type of ultrasound picture would be there in the endophthalmitis also, where there is an infection in the vitreous cavity. You would get these type of mild to moderate amplitude spikes. Is it clear, everyone? Okay, so this is a patient of a vitreous hemorrhage. Okay, so next question is, a 3-year-old child came to the OPD and he is basically being diagnosed as amblyopia. He is not opening the eye, so you have done a ultrasound B scan for the patient. What is the diagnosis in the patient? Now you can see here there is a strand which is being from anteriorly going up to the optic nerve head. Okay, so now what is this disease? So yes, anyone? So this is a persistent hyperplastic primary vitreous. Now what happens is, during the embryology, there is a persistent hyaloid artery. There is a hyaloid artery which, with development, it basically disappears. But if this is still remaining there, it can, first of all, in the back side of the lens, it can be there as a Mittendorf dot. Okay. Second thing is, you would see a strand which is going to the optic nerve head. This is basically called a persistent hyperplastic primary vitreous, and sometimes it is such a thick strand that it can basically present like a leukocoria as well. So this can be a differential diagnosis of a leukocoria as well. Okay, remember, whenever you get a retinoblastoma, I would show you a picture of retinoblastoma. So in retinoblastoma, you would get a mass like this. Can you see here? You would get a big mass like lesion in the vitreous cavity. This is not a patient of retinoblastoma. This is a PHPV. Now you would ask me, sir, why not a ROP? Remember, in the retinopathy of prematurity, you have the tractional retinal detachment. Okay, so you would have retinal detachment, and retinal detachment comes like this picture. Okay, you have membrane, and behind the membrane there is a fluid connection. Can you see? Here you are seeing in this picture, you are seeing that there is only a strand, no membrane and nothing like that. Okay, so this is a picture of PHPV. This is not a patient of a patient of a retinoblastoma or a ROP. Is it clear, everyone? Okay, so with this I end this session of the investigations in ophthalmology. Now we are left with some important questions and the systemic ophthalmology. Most probably we would basically finish it by 5:30 to 6 o'clock. So be there after the lunch break of 45 minutes. Okay, so we would be there again by 2:45 or 2:50. Okay, chalo.